So Nick here, let's talk to you about the EFAST examination. So how are we going to do this? Combination of the right upper quadrant, pelvis, left upper quadrant, and subcostal view. And then the thoracic component, which would include the pericardium and pneumothorax. So the order is entirely based on your injury pattern. If it's mostly abdominal pathology you're dealing with, you start with the abdominal compartment. If it's in the thoracic compartment, you start thoracic, obviously, first. Okay, so in the abdominal compartment, if you're going to start it this way, right upper quadrant followed by the pelvis in the longitudinal fashion, then the left upper quadrant, followed by the other exam, which is the thoracic component. Depending on where your injury pattern is, the right upper quadrant is the most sensitive part of the examination. Obviously, for the EFAST examination, once it's positive in one area, that's it, your test is positive, you are done. You may want to delineate thoracic pathology, obviously. So let's talk about the right upper quadrant. So start in the right upper quadrant. Okay, anatomically, this is where you're going to look. Direct your probe towards the patient's spine. Direct the probe face towards the patient's spine. This is the image that you should expect to see. So this is caudal tip of the liver coming into Morrison's pouch. This is the kidney. Blood tends to appear here as a black line, and then after that it slowly tracks in there as there's more and more fluid. Okay, you can see here quite subtle. In this point here, this is a positive EFAST exam near the caudal tip of the liver. Okay, if you look only here, you don't really see any free fluid. Over here, caudal tip of the liver again, and this is the paracolic gutter. You can see free fluid here. Over here, you can see you should fan through the organ. As you can see, there's a very subtle hint here as you fan through the organ. Over here, this is obviously a very seriously injured patient, and this is a very, very positive EFAST examination. The more astute of you would have seen that there is also free fluid or what seems to be a pleural effusion. If this is traumatic, you are expecting a hemothorax. Again here, a very large amount of free fluid. You can see even anterior of the caudal tip of the liver, you have free fluid up to here as well in Morrison's pouch. A lot of free fluid. So now going on to the next examination. So if you had no free fluid in the right upper quadrant, you go look in the pelvis. Okay, so over here you see this is the transverse view where the probe marker is towards the patient's left. But I would prefer that you just use with the probe marker facing the patient's head. Okay, so it's a longitudinal view. So what do you see? So you see the bladder. Okay. You may see, depending on male or female, you may see the uterus, you may see the vaginal vault. In males, you may see seminal vesicles, and you may see the prostate as well. Okay, so let's have a look at this. As you can see here, this is bladder. All right, that's a transverse view. Okay, longitudinal view again. See free fluid here. All right, here this is the bladder, free fluid above. Okay. Again here, now which one is the bladder? All right. So the bladder is over here, free fluid is over here. Oh, excuse me, bladder is over here, free fluid is over here. Okay, again, bladder in the longitudinal section, free fluid over here. Okay. Here, obviously, lots and lots of free fluid just above the bladder. Okay, these structures here, that's bowel. Okay, left upper quadrant. So this is usually the last port of call. You start in the left side, and you really need to be quite high, quite cephalic, so towards the head, and your hand needs to be pushing into the patient's bed. So you need to be quite posterior as well. What do you see? So spleen, okay, kidney. This is the thoracic component. Or the thoracic compartment. Okay, you see over here, free fluid tends to appear above the spleen. All right, as you can see here, there's a little bit of free fluid here. Okay, it's not between the kidney and the spleen; it's actually above the spleen. Over here, you can see large amount of free fluid, okay, above the spleen, so that appears black. Okay, again, large amount of free fluid, but between spleen and kidney, there doesn't seem to be a lot of free fluid at all. Okay, pitfalls. If you don't look at the caudal tip of the liver, okay, you may miss free fluid. So here we go. So you can see here, sliver of fluid, quite a bit of free fluid here. Okay, so don't forget to look at the caudal tip of the liver. Don't forget to fan through the organ. All right. Okay, as we have said, positive, you move on to the next part of the examination, which is probably the thoracic component. Okay, thoracic component, okay, so looking at the pericardium, so probe marker towards your left again, direct it upwards, okay, and maybe slightly to the left, all right. You may have to push down quite hard, and what you should see here is you're using the liver as an echogenic window. You're using the liver as a sonographic window because it's full of blood. So you should see the heart, and mainly what you're looking at is the pericardium. You're looking to see whether there's blackness in between that and the myocardium, okay, which would signify free fluid. And in this case, it'll be a pericardial effusion. Now, whether the patient is shocked, or if he's looking very well, reading newspaper, okay, this if he's reading newspaper, the pericardial effusion is there probably a long time. If he's looking very, very bad, then it's likely that is probably tamponade, or that small amount of free fluid or pericardial effusion is causing tamponade physiology. Okay, so go clinically by what the patient looks like. What does a tamponade look like? So it looks like someone jumping on the right ventricle. The right ventricle is not able to fill, leading to a shock state. Okay, over here you can see there's a collapse of the right atrium, and the right ventricle is not filling properly as well. Heart is kind of swinging in this pretty large pericardial effusion. This is probably not acute. This is probably a medical type pericardial effusion, be it from renal failure, be it from some sort of cancer. Okay. Over here, if you had an ECG, you'll see electrical alternance because the heart is shifting from left to right. Again, you can see impaired filling of the right atrium. The patient, you would be very, very suspicious of impending pericardial tamponade if he's not shocked already. Okay, again, if you don't know what it looks like or you cannot recognize tamponade, if the right ventricular free wall is doing the John Travolta on you, that is likely pericardial tamponade is not going to be able to fill properly. Okay. Here you can see a clot. Okay, so this is traumatic pericardial effusion. So you can see what looks like part of the myocardium, but in actual fact, this is consolidated, or this is a clot that has actually consolidated, and it looks kind of gray. Okay, but you can see that there's blood in there as well. All right, so this don't mistake this for part of the heart and think that this is a small pericardial effusion. This is not. Going at this again, okay, so this is a pretty large pericardial effusion, quite difficult to see, quite grainy, but again, right ventricle is not actually filling properly. You see there's no ability for the right ventricle to fill at all, leading to this shock state. Okay, pneumothorax. As long as you know where to place the probe on the chest wall, you should be able to come up with this, which is the pleural line, 2 ribs on either side, okay, probe marker facing to the patient's head. You should see this movement here on the pleural line, and that would signify that there is no pneumothorax, okay, no pneumothorax. So here on the left, you can see lung sliding, the visceral parietal pleural interface. There is sliding because the 2 surfaces are articulating. Over here, you can just see up and down movement of the chest wall from the pectoral muscles. But this is the pleural line, the visceral parietal pleural interface, and there is no movement, okay, no movement of the parietal interface, pleural interface, and that would suggest that there may be a pneumothorax there, okay. Over here, this is what we call a lung point, okay. This is a lung point. This is where the lung actually starts to separate from the two pleura, start to separate from one another. Okay, so you can see here, this is a lung that's actually still articulating with the visceral pleura. The visceral and parietal pleura are still articulating, but over here, visceral and parietal pleura are no longer articulating. So there's air in this space, suggesting a pneumothorax. This is pathognomonic for a pneumothorax. Over here is one of the pitfalls of